You don't even really want to say hi. What the heck is wrong with you? Huh? What you think? Greetings, everybody. I miss y'all. I've been kind of bored this week. Also been kind of sick since Thursday. So, if I start having a coughing fit in the midst of all of this, bear with me. Supposedly there's some AI that'll edit that out. But anyways, I was actually really excited for this lecture, and I had it all mapped out in my head, and I could stand up in front of you guys super easy and go through all of these slides. But then I've got it rehearsed in my head, and then the camera turns on and I become what I feel like to be a completely staggering idiot. So my voice sounds a little bit off. It's because I've been sick. If this really sucks bad, I'll just start the recording over. But we are going to start trudging through the incredibly important topic of cardiovascular pharmacology. Starting now. If I can get the slide to advance. And I can. Hooray. All right. So what are we treating, guys? We have gone pretty in depth with cardiac anatomy, moderately, maybe just skim the surface of cardiac physiology. And we've also talked a bit about pharmacology, and we've talked a good bit about different forms of heart disease, especially in our dogs and cats. And if you have not had the opportunity to go back and review your companion lectures, this would be a really good time to do so, because hopefully having your A&P, having your pathology from companion, getting now to the pharmacology, having a basis in those things, my hope is that things will really start to kind of click for y'all. But with respect to cardiovascular disease, we are treating a lot of different things in our different species that may also have different pathologies. We have things like mitral valve disease. We have dilated cardiomyopathy, which is a disease of the muscle. We've got heartworm disease, which ends up being a right-sided heart disease due to the physical presence of worms sitting in the pulmonary arteries, and over time causing inflammation and also causing truly occlusion to some extent of those vessels. And then we'll also have the occasional congenital heart issue, which is something that these animals they have at birth. Now, I know we talked about it in companion, but we do not have nearly the ability or extent to treat heart disease surgically or with advanced imaging type procedures and catheterization under fluoroscopy that we do in human medicine. What they can do in human medicine with respect to our heart is pretty darn incredible. But we're really limited to medical management and lifestyle modifications, sometimes dietary modifications, and monitoring, just because our pets don't live as long. The accessibility of that technology is out of a lot of people's reach, and just the practicality of it, when you get down to the brass tacks of the cost of it, it is just really not that practical. But there are things that we can do, and we do very regularly. These are important drugs that you're going to be using sometimes in surgery, but often with critical illness. But often you're going to be treating these guys, especially these little heart valve, heart murmur, congestive heart failure dogs. You guys are going to see these in practice every single day. So it's incredibly important that you understand the pharmacology behind the medications that we are going to be filling, dispensing, and communicating to these owners about. So monitoring, as I mentioned, you guys hopefully remember resting respiratory rate from an at-home standpoint is really one of the most important things we can do to monitor chronic heart disease in our patients. So let me move my head around so that pardon, going over to the side. So I'm not in the way of my text. But Cardiac basics. So all these things should be things that you already know. The heart is muscle. It is striated muscle, but unlike our skeletal somatic muscle, it is involuntary muscle. So we cannot control actively our heart rate just by thinking about it. Now, histologically, cardiac muscle does have intercalated discs. Welcome to my life. Lincoln is protecting us from the wind. Heart has 4 chambers and 4 valves. The right side of the heart pumps deoxygenated blood to the lungs. Left side of the heart pumps the oxygenated blood to the rest of the body. That cardiac muscle has intrinsic, spontaneous contraction, and regular control of that contraction is mediated through the nervous system of the heart. The sinoatrial node is that major pacemaker. Cardiac contraction is also all or nothing. And so those cells, if you take them out of a heart, a small population of cells, and put them in a dish, they will want to beat on their own. That is called automaticity. When we have disturbances of rhythm or conduction in our cardiovascular system, we call that an arrhythmia. And please remember that calcium plays an important role in cardiac muscle contraction. There's literally nothing happening in my house right now. Like, it is the wind, a leaf, a raccoon outside. Like, this is like just the chronic noise and chaos. All right. Next up, we're starting again with terminology. Cardiac output. And this was the basis of that video that I had asked you guys to watch. I'm going to move my head over again. That basis of the video I asked you guys to watch. Cardiac output is the core of how we make pharmacological modifications in the face of cardiovascular disease. Cardiac output is the volume of blood the heart can eject in 1 minute. And it is a simple formula. Stroke volume, heart rate. Right over there. And that little nursing video. Oh my gosh. Next. No, thank you, next. My slides won't advance. There we go. All right. Stroke volume is the volume of blood that is pumped with each contraction. So every single contraction, that is the stroke volume. We take that stroke volume, we multiply it by the heart rate. That gives us the cardiac output. Stroke volume, as you already know, is influenced by 3 major players. Number 1, preload. Number 2, afterload. And number 3, contractility of the heart muscle. And that contractility of heart muscle also has this name here that is probably going to be new, but it is called inotropy. That is just a fancy medical scientific term for contractility of muscle. It's inotropy. Oh, I don't like why this keeps doing this. Just move along. There we go. Oh, now I moved too far. Boy, this is really becoming a shit show real quick. There, I'll just go down there. Okay. Other terms that we see with respect to the heart. In addition to inotropy, you'll also see the term chronotropy. The prefix chronos means time. So chronotropy means regarding the speed of heart contraction. So a chronotrope is something that affects the heart rate. A positive chronotrope is something that would speed the heart rate up. A negative chronotrope is something that will speed the heart rate down. Now, there is one other term with respect to cardiac muscle here and medications that affect cardiac muscle, and that is dromotrope. You're not going to see dromotrope very often, but when something is referred to, specifically if a drug is referred to as a positive or negative dromotrope, what that is referring to is the speed of the conduction of the electrical impulse through the heart, not the actual speed of the heartbeat, but the speed of the conduction of that electrical impulse. You know, that one that starts at the SA node, goes to the AV node, goes through the bundle of His, and then down into the Purkinje fibers. I feel pretty good that most of you guys have a good handle on that, but that term is dromotrope. So you may see it in terms of medications. And when we start talking about dromotropes, we're almost always going to be talking about things that are treating cardiac arrhythmia. And honestly, I'm not going to use the term very much. I just wanted you to be able to be familiar with it in case you see it somewhere. Now, influencers of stroke volume. I really think I'm funny sometimes. Like, I think this is causing me grave chaos here. I don't know how I did this before. Okay, now I'm up in that corner. Stroke volume influencers. I like my photo there. I think I'm funny. Preload. Number one, that is part of that video that you watched. Preload is the stretch on the wall of the ventricle due to the volume of blood being returned to that ventricle. Right ventricle or left ventricle. Honestly, guys, for practical purposes, can really think about these terms with respect to the left side of the heart, but know that it affects both sides of the heart. Afterload is the resistance that ventricle must pump against in order to get that semilunar valve open. So we've got preload, we've got afterload, and then we have the contractility or the inotropy of the muscle itself in this equation. The technical definition of inotropy is what you see right there in italics and parentheses. Inotropy is length-dependent activation of cardiac muscle. That's a lot of words, but you can think of it more simply in just in terms of how strong is that heart able to beat? How strong is the contraction of that muscle? That is the most important thing. All right, heart rate. Heart rate is the other half of that equation that I had you guys watch the video over. So we got stroke volume, heart rate. So, stroke volume equation. I tried to do some fancy animation stuff with this, so we'll see if this works or sucks. You let me know later. All right, let's see. It won't even zoom. Oh my gosh. I hit the right button. Okay, so let's think about what type of things influence our heart rate. What makes your heart speed up? What makes your heart slow down? You know the answer, and the answer is the autonomic nervous system, sympathetic nervous system, fight or flight, epinephrine, norepinephrine. Those will increase your heart rate. They will increase blood pressure. So your nervous system plays a role in all of these factors with the heart as well. The sympathetic nervous system has alpha and beta receptors. You are going to hear the terms alpha and beta with respect to some of these cardiac medications. And so they are either going to be blocking those sympathetic nervous system beta receptors or blocking the alpha receptors or stimulating those receptors, meaning they are either agonists, ones that turn on the receptor, or antagonists, those that block the receptor. All these terms, they come right back together. And then, what slows the heart rate down? Rest and restore. Parasympathetic nervous system. The parasympathetic nervous system stimulation is largely mediated by the vagus nerve, cranial nerve number 10 for the win. Please remember, acetylcholine is the major neurotransmitter of the parasympathetic nervous system. The parasympathetic nervous system has nicotinic and muscarinic receptors. I don't care that you know that cold, but just be able to associate those words with the parasympathetic nervous system. When we turn on the parasympathetic nervous system, the heart rate decreases. That is why a drug like atropine that we talked about in our pre-medications, which is a parasympatholytic, lytic meaning stopping, killing, and an anticholinergic, meaning I work against acetylcholine down here. That type of medication that blocks the parasympathetic nervous system, that blocks the action of acetylcholine, raises the heart rate. It does all tie together. All right, you guys I'm pretty confident you know your anatomic structures of the heart well, because you know your blood flow. Now, the white arrows in this diagram, these are schematic representations of the direction of electrical flow in the cardiac conduction cycle. So this is the nervous system of the heart. SA node, AV node, little bundle of His right here, coming down into the Purkinje fibers here. That is what initiates that heartbeat. So that is the electrical activity of the heart. Now, when we are treating disorders of the cardiovascular system, what can we actually do? What we can actually do with medications is we can affect those mechanisms that control heart function, cardiac output. So number one, we can use medications that change the rhythm or the heart rate. In general, we call those chronotropes or dromotropes. We can reduce with our medications now, guys, we can reduce our preload and our afterload using diuretics and vasodilators. So diuretics help to pull water out of the bloodstream and eliminate it through the kidneys. And we're going to talk about them later in this lecture. And that helps to reduce preload by reducing the amount of volume that is returned to the heart. So therefore, there is less stretch on that already failing, already compromised heart. We can reduce afterload by using vasodilators. So things that dilate the resistance, that dilate blood vessels, that reduce afterload that heart has got to pump against. Or we have some drugs, and really one in particular with respect to small animal medicine, that is an actual inotropic drug. It actually improves the ability of that heart muscle to contract. And so that drug is called an inotrope, and it is called a positive inotrope because it's increasing the force of contraction. So those are the three basic categories that we're talking about when we are looking at medically managing cardiovascular disease. Now, we're going to start with the inotropes because they're biggies. So positive inotropes, positive meaning I increase something. So I'm increasing the strength of that contraction. So I've got a heart that's failing and I can increase the strength of contraction of the muscle. So these drugs are actually acting on the muscle. There are really only two that you need to know. And really, truthfully, there's only one that you need to know. And it's not the one that's on this slide. The one that's on this slide is digitalis, or digoxin is one of the old trade names. Digoxin is what is considered to be a cardiac glycoside. It is a component of a flour. I have a picture in here of it. But digitalis, for a long time, was the only medication that we had that functioned as a positive inotrope. It was the only thing that we had available in veterinary medicine that would increase the force of heart contraction in the face of congestive heart failure. Now, it does some positive things. It does increase cardiac contractility. It also acts as a negative chronotrope by decreasing the heart rate. So if you remember in terms of congestive heart failure, when the heart starts to fail, if it ain't fast, it ain't failing. The body says, I'm not getting enough oxygen from those erythrocytes. Get to work. So it kicks that sympathetic nervous system in gear and it increases that heart rate in order to provide for that oxygen demand for the rest of the body. So as a general rule, if a heart is not beating fast or tachycardic, then that heart is probably not failing, so to speak. So digitalis improves cardiac contractility. It decreases the heart rate. It does have some antiarrhythmic effects. It will decrease the signs of dyspnea. So everybody remember dyspnea, respiratory distress, essentially, or respiratory insufficiency, could also be tachypnea. It works at the level of calcium ions, and that is where these inotropes all work, is calcium ions. Remember, if you go back and review your cardiac muscle physiology, your skeletal muscle physiology, calcium is incredibly important for those actin and myosin filaments to contract upon each other, more so than pretty much anywhere else in the body. So it does so by blocking the sodium-potassium ATPase pump. Digitalis is really only used like never anymore. If you see Digitalis being prescribed for a patient, there's a really good chance that if this is, honestly, you're not going to see it unless you are, because the other drug that we have for it is so much better and so much safer, because this is not a very safe drug overall. So I can remember prescribing it maybe twice, like way at the beginning of my career. But now most hospitals don't even carry this drug. And so the reason that you need to know it is because it is historic medication. A lot like when we talk about halothane with the inhalant anesthesias and methoxyflurane. It is a historic drug of record. And these historic drugs of record are not very common, but they're not uncommonly found on things like VT&E questions. But the practicality of this actual medication is slim. Like, you're not going to use it. You just aren't. It is a drug we very rarely use in cats, if at all. In fact, we rarely use it in dogs anymore. But it's still one of those that you supposedly need to know. Now, other drugs that could be positive inotropes. Okay. If you notice, there was a tiny little gap in the filming. I had a wardrobe change because I was literally sweating my ass off in my 25-degree bedroom, just having to project this on the phone. And then you heard the absolute chaos that is the wind, a leaf blowing that happens probably every 20 minutes in my house. Then my husband, who I told he better come in and get a shower underway because I need to sit in here and record a lecture for you guys, came out of the shower, clothed, thanks for small favors. And I don't know if you guys have met Gordon, but like Gordon's really like, he's buttoned up. Like, he's former military. He's super quiet. He like stays in the shadows. Like, if you ever see him at a function, he will be like over in the corner against the wall, maybe looking at his phone, and then he might just disappear. That's his normal. Well, he came out of the bathroom and started like shaking his ass while the dogs are barking. I'm like, I paused it just right before I got to the, what the actual fuck are you doing? And he thought he was hysterical. So apparently that trend runs in our family. But I digress. I've had a wardrobe change. I am currently now hot to go in the 20-degree weather. So we were talking about positive inotropes and the catecholamines. Hopefully you have some recollection of maybe having heard the word catecholamine, because we've talked about catecholamines, maybe haven't like really reinforced that term. The catecholamine, damn it, I just paused it again because I thought I was being slick with my animation. Oh my gosh, this is a nightmare. Hey, there we go. Okay, so where are the catecholamines made? The catecholamines, quite simply, are your fight or flight hormones. So epinephrine, norepinephrine, those come from the adrenal glands. Remember our adrenal glands, they sit right above those kidneys there, and they have an outer cortex, and then they have a central medulla. The outer cortex produces glucocorticoids, which are our cortisol, so our stress hormone that helps us to be resilient in the face of physiologic stress or environmental emotional stress. The medulla of the adrenal glands is what produces those more sympathetic nervous system hormones, so epinephrine, norepinephrine. Let's see. Okay, so epinephrine. What does epinephrine do? Epinephrine acts on the beta receptors, particularly the beta 1 receptors of the sympathetic nervous system in the heart. When epinephrine takes effect, it increases your heart rate. It increases the force of contraction. So that makes it a positive chronotrope because it increases the rate, but it is also a positive inotrope because it increases the force of contraction. It also increases systemic blood pressure via constricting the blood vessels. If you remember back to A&P, our veins and our arteries have a layer of smooth muscle within them. Which has more? Hopefully we remember the arteries do. And hopefully remember that the aorta is the largest muscular artery in the body. So, epinephrine. When we talk about utilizing epinephrine as a pharmacologic agent, there are only two indications that we are going to use epinephrine. Number one is our dying cardiac arrest patient. So it is a rescue drug. So we use it for cardiac arrest. We use a combination of epinephrine because that increases the heart rate, increases the force of contraction of the heart, increases the blood pressure. Then while we're doing compressions, we will also give what other emergency drug during CPR? Atropine, our parasympatholytic drug. So we are trying to stop any action of the parasympathetic nervous system while kick in the action of the sympathetic nervous system in CPR. That is how those drugs can have an effect on the heart. Now, you will also occasionally, if you're working in emergency practice, have the need to use very low dose epinephrine, sometimes with true anaphylactic reactions. Anaphylaxis, type 1 overreaction of the immune system, the type where the animal wants to die. So what happens with anaphylaxis? We have massive histamine release. Histamine is a major vasodilator. It causes circulatory collapse. So you get massive acute hypotension in response to it. You can also get tachycardia and bradycardia. It usually starts with tachycardia because the body says, oh shit, we don't have enough oxygen, get us more, and the heart starts pumping faster. But as that cycle continues and the heart still can't keep up, it will get slower. So we use anaphylaxis. We don't use anaphylaxis. We try to avoid anaphylaxis, but we utilize epinephrine in a low dose, IV, IM, or sub-Q to help counteract the effects of anaphylaxis. Isoproterenol is another drug. You might see it somewhere. We don't use it. You just need to kind of have a sense of having seen it somewhere in case it ends up on an exam question. It won't be my exam. Then dopamine and also dobutamine. So dopamine and dobutamine. Dopamine specifically stimulates the alpha and the beta adrenergic receptors of the sympathetic nervous system, thereby increases cardiac contractility, heart rate, and blood pressure. Dopamine is not a single dose. It only comes in an injectable form, and it has to be given as a continuous rate infusion. And if you have a patient that requires dopamine or is on dopamine, I guarantee you are going to be in a 24-hour specialty center or a tertiary referral center because this is only for use in really critically ill patients. Likewise, dobutamine may be seen and used a little bit more commonly. It is a beta-1 adrenergic, so it is used primarily in diseases like dilated cardiomyopathy, where the muscle is weakened and expanded and dilated and thin, and so we're trying to give a drug that helps to increase that contractility. Again, dobutamine is an injectable only. It must be given as a CRI only, so the practicality of it is not fantastic when we're thinking long-term patient wellness. So if you're using these, you're really only going to be using them in emergency and critical care type of settings. So here is the one you need to know. This one, you will use it every day. I cannot get myself out of any of I'm just going to move myself around. Can you chase me? Can you catch me? Pimobendan. This is a wonder drug, guys. This is the Serenia of cardiac pharmacology. And so pimabendin was approved just since I have been out of school. So it was officially approved in 2007 for veterinary use. It is technically approved for dilated cardiomyopathy and myxomatous mitral valve disease, MMVD. It is an amazing drug, a wonderful drug. It doesn't save lives, because once your heart starts to fail, you guys, like, that usually is going to be the thing that gets our patients if they have some degree of heart disease or heart failure. But pimabendin will substantially prolong lifespan and increase the patient's quality of life. It does that by increasing the calcium sensitivity of the myofilaments of the heart muscle. So it makes them more sensitive to calcium is there. And by doing so, it increases inotropy, increases the contractility of the heart. So therefore, it falls into the category of positive inotropes. And it is the most important positive inotrope you need to know. Now, pimabendin also has a second effect that is not about the contractility. It has what is called phosphodiesterase enzyme inhibition. So PDE, and usually PDE5 is how it's going to be abbreviated if you're reading something about it or you're reading the package insert. I would absolutely recommend that you guys read through the package inserts with these drugs when you get out into your externships. Like, it will click lights on for you. But what that does, that phosphodiesterase inhibition decreases blood pressure. So by doing that, and it has the phosphodiesterase has a very unique effect because it produces what is called balanced vasodilation. So it produces relaxation of those blood vessels both on the venous side and on the arterial side, which reduces effectively the preload and the afterload of the heart. So it makes the heart pumps harder. It has less force to contract, and that's resistance to press against by that arterial vasodilation. And it also allows for a slight degree of venous dilation, which, if you're thinking about that right side of the heart and blood return and stretch into the ventricle, that slight amount of vasodilation on the venous side of things has an effect on the preload of the heart. So it does all three components of that stroke volume. The main one, though, that does, though, guys, is that contractility. That I would focus on the contractility as the mechanism of action. Therefore, we call it a positive inotrope. Now, when don't we use pimabendin? Pimabendin, because we are talking about a drug that increases the force of contractility, makes it pump harder. So diseases like dilated cardiomyopathy, diseases like valve disease, where that valve starts leaking, and over time, the heart wall just keeps stretching and stretching and stretching because of that increased preload and increased afterload. Then the contractility suffers. Diseases where we don't have this, but are very significant heart diseases, hypertrophic cardiomyopathy. Remember what the heart looks like when it becomes diseased in cats. Hypertrophic cardiomyopathy is a thickening of the heart wall, particularly that left side of the heart, guys. And that thickening increases by the disease itself, increases the inotropy. Those cats do not need more contractility in that super muscular heart. It is already working hard enough. And if we add any more contractility to that heart, we are setting those cats up for problems. So it is not recommended for hypertrophic cardiomyopathy. So this is not a drug that you are going to see prescribed in cats. Now, likewise, aortic stenosis. Hopefully, if I was in class, I would ask you if anybody remembers what aortic stenosis is. But aortic stenosis is typically a congenital heart defect. We are talking about the aortic valve. That is one of our semi-lunar valves. And when that valve is stenotic, it means it doesn't open well enough. So you have increased afterload pretty much from birth in those guys. So if you have a condition that's a structural issue, like aortic stenosis is, pulmonic stenosis on the right side of the heart, but if you have a structural issue that is already making it very hard for that right or left side of the heart to push blood out, if we have a high degree of afterload that we can't fix medically, because we can't fix aortic stenosis unless we go in and replace the valve, which is what they do in you and I, or sometimes they'll go in dogs and they can do a balloon dilation. So that's tertiary medicine. So universities, specialty centers are going to be doing that sort of thing, and has to be the right candidate. You go in with a balloon, you can dilate it a little bit so it doesn't have that degree of afterload or resistance. We don't want to be giving a drug in that circumstance that makes that heart pump even harder against a teeny tiny little hole that it's already trying to shoot blood out of because that valve is not functioning properly. So pemobendin is not appropriate for things like aortic stenosis, and generally not appropriate in cats with hypertrophic cardiomyopathy. But 100%, guys, it is the drug of choice for congestive heart failure, for early dilated cardiomyopathy, and myxomatous mitral valve disease. There are recent studies now that have shown, because a lot of folks are like, this is a really great drug. We see very little in terms of side effects from this drug. Can we start? And it's making a huge difference for our patients. So would there be any benefit in this situation to starting this drug before our patient is in heart failure? And so they actually studied this, and they did a retrospective study and a prospective study of these. And they have since, this is American College of Veterinary Internal Medicine / Cardiology. These are the DVM guru specialists in their field. And so they're much like technician specialists, there are veterinary specialists, DVM specialists as well. All of them get together usually every 3 to 5 years, and they publish consensus guidelines. And what consensus guidelines are basically just the biggest brains saying, based on all of the scientific research that we can put together, this is how we recommend you treat this disease. This is how we recommend you treat that disease. And so every specialty will have its own ACVIM consensus, and these are readily available online if you ever wanted to Google them. But I say all this to say that recently, and it's been just within the last probably 3 or 4 years, the cardiology folks, the big brains in cardiology, have added to their consensus that starting this drug, pemobendin, or vetmedin is the trade name, which is the photo that you see here, does benefit patients that are started on it prior to actual heart failure. So this slide was in your companion lecture here, and that's, of course, our Cavi, who is our poster child for this condition. But historically, we have always started this drug right here in the C level. So when we have first signs of congestive heart failure is when we started pemobendin. The guidelines have now changed, and there is substantial benefit, or at least statistically significant evidence-based benefit, that if we start this drug right here at the B2 phase, where they have definite mitral valve disease, and that is confirmed by physical exam, presence of a heart murmur, then we also have to, the only way to firmly establish B1 versus B2, guys, is to get a diagnostic echocardiogram of that heart, where we take measurements of all the chambers, where we can see just what the outflow is, just how much leakage, how much backflow that we have. So true staging can really only be done with combination of x-rays, echocardiogram, physical exam signs. But now they have confirmed that if we start pemobendin at that B2 phase, and I wanted to go back one, let me go back one, just one, there we go, that it does benefit. So you now, if you think back to our last lectures in sanitation, where we talked about labeling and the drug industry and how drugs come to label approval. And that little caveat that says we can now have conditional approval for some drugs if there is substantial benefit, saying that we can bring it to market earlier prior to establishing that 5-year realm of safety studies. So those drugs are labeled with that CA1 designation, conditional approval drugs. So this looks a little weird sometimes. So you might get into your hospital and see that you have vetmedin on the shelf. And remember that, hey, we've been using this drug since 2007. Why is it labeled CA? That recent ACVIM guideline change is why vetmedin is now CA1 in some circumstances, because the original label for vetmedin only says dogs that are in congestive heart failure, which is that stage C, because our big brains have said, hey, it's just as good for this, and may actually improve their quality of life and quantity of life like 6 to 12 months if we started at the B2 phase. Because of government, because of loopholes, and because vetmedin was not originally labeled for use in B2, stage B2 heart disease, they had to go through this conditional approval designation process for vetmedin. So you might see vetmedin on the shelves with this CA and think, weird, with what we know that it's been out for coming up on 20 years now. But yet it says CA1. That is why. So this particular bottle of vetmedin, even though it is the exact same as the bottle of vetmedin right next to it that doesn't have the CA1 designation, the only reason it is labeled CA1, there's no change to the drug whatsoever, is because we changed the consensus guidelines and to give us that official, quote unquote, legal pathway of prescribing vetmedin for dogs that are not actually in heart failure, at least stage C heart failure. So I said a lot about that, and more than I thought I was going to. Every lecture. Okay, I got to move my head over again. All right, antiarrhythmic drugs. So treating disorders of conduction. Arrhythmias, when we have abnormal conduction in the heart. If you think about disorganized electrical activity in that nervous system of the heart, when that happens in a disjointed fashion, instead of that straight fashion, you're going to get poor cardiac output because that cardiac muscle contraction is not coordinated. It's not going lub-dub. It's going or Arrhythmias occur for a lot of different reasons, though, guys. Arrhythmias do not always indicate the presence of actual heart disease. So things like hypoxemia, general hypoxia of cells, tissues, particularly hypoxemia of the heart, can result in cardiac arrhythmia. So if the heart is not getting enough oxygen through its own blood supply, which is through the coronary arteries, you can get an arrhythmia. If you have major imbalances of electrolytes, remember our blood counts with potassium levels. Super high potassium levels affect nerve impulse conduction, so electrolyte imbalances. Trauma, bruising of that heart. So if we have a dog that's hit by car, a lot of times what we're going to notice first is the presence of injury to the lungs. So pneumothorax, collapsed lung, pulmonary contusions, or bruising, bleeding into the lungs is what we'll see. But the heart can also get bruised in blunt force trauma. And cardiac contusions or bruising of the actual heart muscle itself a lot of times doesn't show up until 1 or 2 days after the event. So it's really important with our hit by car patients, our blunt force trauma patients, that we are regularly listening to them while palpating pulses, right? That is the best way you are going to pick up on a pulse deficit. Pulse deficit almost always indicates a problem with cardiac. Those things can also affect how well the electrical activity of the heart is working. And they don't necessarily have anything directly to do with the heart themselves. So many times, if we can correct the underlying issue. So if we can correct that high blood potassium by unblocking that cat, once that potassium normalizes, there is not any need to treat further arrhythmia. If we have a general hypoxemia because of hypovolemia, dehydration, if we restore that, many times we are going to be able to correct the arrhythmia without actually doing anything to treat the heart itself. But there are times where there is either structural issue with the heart nervous system itself, or there is sustained pathology, or there is such significant disease elsewhere that we have to give medications to help treat and correct the arrhythmia. Because again, arrhythmia means crap cardiac output because that muscle is not contracting synchronously. So fast arrhythmias are tachy, and those can be atrial, those can be ventricular. I know we just very quickly went through them in companion, and you don't need to have an in-depth recognition of arrhythmias, but you do need to be able to pick up on an arrhythmia and be able to look at an ECG and be able to say, does that look like normal electrical activity or does it not? You need to be able to listen to your patients and palpate the pulses at the same time. You got to be able to do that. That's so important, especially with your sick patients. So you can also have flutter or fibrillation. Now, flutter is usually a term that is referred to with respect to the atrium, and atrial flutter or atrial fib. That's a bad thing. Irish Wolfhound is absolutely the poster child for atrial fibrillation in dogs. Otherwise, it is not a very common heart condition. Fibrillation, rapid uncoordinated activity. So it's doing this. It's doing this shit. That animal is going to die if we don't do something really quickly. You actually have ventricular fibrillation. That is one of the very rare circumstances where you actually should be getting out the shock panels like they do on TV and shocking that dog to establish a normal rhythm again, and then trying to fix the underlying problem. But I digress. But when it comes to antiarrhythmic medications, there are some big ones that you do need to know. They are not necessarily drugs that you are going to be using on a day-to-day basis. But here's our heart. Here's our nervous system of the heart, our SA node, our AV node, our bundle of His, our left and right bundle branches, and then extending down into our Purkinje fibers. P wave here, atrial contraction. PR here. That is when the impulse hits that AV node. QRS, that is ventricular contraction, depolarization. And then the T wave is ventricular repolarization. Now, drugs that we use to treat these, 4 classes. Class 1. Class 1, block sodium channels. I feel like you know this because we've said it a lot with respect to lidocaine, because lidocaine is a class 1B drug, but these class 1A drugs block sodium channels in the nerve impulses. And by doing so, it helps prevent uncoordinated electrical activity. So they call them membrane stabilizers. There's class 1A and class 1B. You're not going to use class 1A very much, guys. Procainamide is one of them. We use it for premature ventricular contractions. Quinidine is an alkaloid for ventricular arrhythmias and AFib in horses. I have no idea if horse people actually use quinidine. I have never touched it as a small animal practitioner, but that is the label indication for quinidine. Now, class 1B drugs. This is going to be the one you use most commonly, lidocaine. It blocks sodium channels. We also know that because it is acting on the nervous system and it's blocking those sodium channels, this also makes it very useful as a local anesthetic. So lidocaine, even though topical anesthetic, antiarrhythmic, the way it's doing both of those things is the same, guys. It is blocking sodium channels of nerve impulses. Just when we give it systemically or IV, we're doing so to get it to the heart for that electrical conduction of the heart. When we give it as an injection into the skin, we're trying to block all these little nerve impulses in a small area to induce sensation of anesthesia or analgesia, so loss of pain and loss of sensation. So, for antiarrhythmic purposes, pardon me, it only comes in that injectable form, and we can use it as a bolus. So initially, usually like 2 to 4 milligrams per kilogram IV, and then usually if there is a sustained need for it, and I'm going to tell you right now, there's almost always going to be a sustained need for it, then we need to get that patient on a CRI. So we use it almost exclusively for ventricular tachycardia. You need to know this about cats, guys. Cats are more sensitive to lidocaine. And because lidocaine affects the nerves, and cats are more sensitive, so the way that their body reacts to the drug or pharmacokinetics of the drug results in central nervous system effects. So they are much more likely to suffer signs of toxicity. So when we're giving lidocaine to cats, we need to be pretty cautious that we don't exceed the maximum dose and that we monitor our patient for those particular central nervous system effects. Now, there is an oral formulation of one of these class 1B drugs. I call it basically oral lidocaine. It's not lidocaine, but its name is mexiletine. So if you have a patient that has some underlying arrhythmia that needs continued antiarrhythmic, the hospital, or we're trying to switch it over to orals, because again, when we're on CRIs, that means our patient can't go home. So ultimately our goal is to get most of our patients home one way or another. So mexiletine occasionally does get prescribed for at time of discharge for oral use. Mexiletine is expensive. I've prescribed it a couple times for some persistent ventricular tachycardia. So we saw a normal ECG. This is an abnormal. And again, lead 2 is most often what I'm going to be looking at. So we do not have our normal PQRS here. We've just got wide, bizarre, irregular QRS complexes. I don't really even see a P wave. I don't see a P wave. So this is a problem. So this is a patient that needs some lidocaine really quickly. All right, class 2 antiarrhythmics. What you need to know about class 2s is they fall into the category of beta blockers. You guys have probably heard the term beta blocker, but not had any sense of what that means before. Now, hopefully, ta-da, you can start having an idea of what the term beta blocker is actually referring to. When you hear the word beta, that is referring to the beta adrenergic receptors of the sympathetic nervous system. It is blocking those receptors. So if we know our sympathetic nervous system, which is the catecholamines, epinephrine, norepinephrine, if we're blocking those effects, beta blockers then decrease the heart rate. They reduce the automaticity of cardiac conduction, so they slow the rhythm down. The major 2 of these beta blockers that you will hear or see, or some of you may even take some, one is called propranolol. The other is called atenolol. They are just slightly different. Propranolol does beta 1 and beta 2 blockers. There's alpha 1, alpha 2 in the sympathetic nervous system, and there's beta 1, beta 2. So propranolol does both. But when we slow this heart down, because most of the time, a lot of our arrhythmias, and we're using these mostly to treat tachyarrhythmias, so fast arrhythmias. If you think about a heart that is beating faster than it should, what does that heart muscle have need of? Increased oxygen demand. And so we've got a heart that's got a conduction abnormality. It is beating faster. It is having a hard time getting oxygen. By slowing it down, the blood vessels of the heart itself, those coronary arteries and veins, can fill more completely. Those cardiac muscle cells get more oxygen overall. So it decreases the oxygen demand of the myocardium. It needs that oxygen. So what these beta blockers do is it decreases the heart rate, and it decreases blood pressure, and also decreases cardiac output. And that is not always a bad thing with some of these patients. But we don't want to use this in animals that already have kind of slow heart rates, really poor cardiac output, or really significant hypotension. So there's not a ton of use for these drugs in veterinary medicine. But if you think about the physiology, you think about the pathology, a drug like a propranolol is going to be more beneficial for things like cats that have a hypertrophic cardiomyopathy, because those also have and cats that have hypertension. So in a hypertrophic cardiomyopathy where the muscle wall is already thick, and a lot of the time it's already beating pretty dang fast, if we can slow it down a little bit and decrease that oxygen demand, we're probably doing our patient a lot more good. Propranolol, again, we don't use these a ton. More than anything is I want you to understand, like, what does this mean when we say beta blocker? What is it doing in the body? And kind of what kind of patients would it be appropriate for? Because truthfully, you're not going to pull it off the shelf like super often in general practice. Now, this one, you might a little bit more. These class 3 antiarrhythmics. So, class 3 antiarrhythmics, they block the potassium channels. So they work a little differently than lidocaine, which blocks the sodium channels. Class 3 agents block potassium channels. And by blocking the potassium channels, hopefully you can remember or look back on your nervous system lecture about the flow of electrical impulses. Like you've got your sodium channels and you got your potassium channels. Your sodium channels open, electrons flow in, then your potassium channels open and things flow out. So when we block those potassium channels, it is slowing the repolarization of the heart. So it is keeping it from these crazy beats down here where we've got a normal heartbeat and then we've got boom, boom, boom. And these happen in rapid succession when this happens. So if we can slow that conduction down, then a lot of times we're able to prevent this disjointed arrhythmia here. If we can just slow it down, like the heart kind of self-corrects to a degree. The major one of these drugs that if you use them at all that you will see used is sotalol. As one I have prescribed a lot over the years. If you remember our discussion about boxers and arrhythmogenic right ventricular cardiomyopathy in boxers and this crazy arrhythmia these guys get. This is the drug that we use for this. It doesn't fix them. It may improve the quality of their life and it might improve the quantity of their life because sudden death is a big characteristic with these guys. But if I have a patient that has got a sustained ventricular tachycardia from something like a GDV, and it's otherwise doing well, and we can get it, but it's been on lidocaine CRI in the hospital, and if we can get it tapered off that lidocaine and then transitioned onto something like sotalol for a short period of time, 5 days, 7 days, and then get it off the sotalol, and then they're going to have a perfectly normal, happy, healthy heart in most instances. That is not the case with ARVC and boxers. There's squat we can do for them, except prepare the owners and give them some sotalol. All right, last class of antiarrhythmics. Again, these are not ones that you're going to use a ton, but they also have a different mechanism of action. The class 4 antiarrhythmics block calcium channels in the cardiac cell membrane. So by blocking those calcium channels, it depresses the contractility and it also affects the automaticity. So that inherent nature of these cells to keep pumping, even if you take a small portion of cardiac muscle out of the heart, it's going to want to keep contracting. So it works at the level of the heart muscle cell. Rapamil, I've never used it. You're never going to use it. Diltiazem. Diltiazem is like the rescue drug of choice for hypertrophic cardiomyopathy cats that are tachycardic, and they almost all are. However, most of these cats are dying before you can ever effectively get the diltiazem in them. When I was at Mississippi State, we were a class 3 AHA emergency referral center, and they also have guidelines, much like our AVMA accreditation guidelines. There are these guidelines that you have to have that says you have XYZ drugs in place. And as a class 3 emergency critical care hospital, you have to have diltiazem in your hospital. In my hospital for 10 years, and it's injectable. It has to be refrigerated, injectable only. It was in a drawer. It was in a drawer for 10 years. It might have gotten pulled out once in 10 years. And that's not just by me. That's with like all the 15 doctors that I worked with there. So it is not one that you're going to be using very commonly. But let's say you go to work for a cardiologist, like that's going to be a drug you might get familiar with. Now, this last one here is one that you will see prescribed, amlodipine. It is an oral medication. It is most commonly used for the treatment of hypertension in cats and dogs. So you may come across an animal that is on amlodipine for chronic hypertension. These are usually older animals. They have other comorbidities. But all of these drugs, like every single one of these cardiac drugs, with the exception of the diuretics, guys, especially, but the antiarrhythmics and the positive inotropes, all of these drugs have relatively narrow therapeutic indices, meaning that you can cause harm. So in day-to-day life, these are not drugs that you may find, especially your really savvy cat practitioners that are doing long-term, feline senior medicine. Amlodipine absolutely may be on your shelves and used for hypertension in those cats. But I haven't used a lot of it as an emergency practitioner because this is a drug, if we're sending it home, like there needs to be some monitoring and some setup circumstances. But every one of these drugs does have the potential to cause arrhythmia or to worsen heart disease. So every drug can be a poison if given in the right quantities with the right other comorbidities. All right. Let's talk about blood pressure. Blood pressure medications, vasodilators or dilating vessels. Congestive heart failure pathophysiology. That's the physiology of the disease process. Initially, let's think about what happens in congestive heart failure. You have a muscle. That heart muscle is weakening and it is not doing a good job maintaining cardiac output. What happens initially is you will get hypotension. So overall blood pressure will decrease because the body is always trying to maintain homeostasis. So the body senses the heart's not doing great, and so it tries to take some of the workload off by dilating those blood vessels a bit. So what happens, though, is you, with hypotension, a failing heart, those red blood cells are not getting where they need to go to carry that oxygen, right? So two big things happen. Number one is your sympathetic nervous system turns on. That fight or flight says, hey, I'm trying to die. Something's wrong. What can I do to get that heart rate up, to get my blood pressure up? So the sympathetic nervous system activates chronically with congestive heart failure at a low level. So it's not constantly running from the tiger, but the body's like, we got to jack shit up here. It is not working. So your sympathetic nervous system turns on and it starts constricting your small blood vessels and it increases your heart rate in a heart that's failing. And then those kidneys, God bless those kidneys. Remember the kidneys, the brain, the heart, those are high blood flow organs. Like, your kidneys require roughly 25% of your cardiac output. They require 25% of the oxygen being pumped around your body. The kidneys go, hey, not feeling it. You need to do better. And the kidneys turn on this renin-angiotensin-aldosterone system. This is a hormonal system regulated by the kidneys, guys. This is the part where we need to start understanding this system. So the kidneys, in response to lack of blood flow or hypoxemia, turn on the renin-angiotensin-aldosterone system. Renin-angiotensin 1 is converted by what is called this angiotensin converting enzyme. Renin goes to angiotensin. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. So there's a flow to this, and I think I've got it on the next slide for you. But angiotensin 2, when we get down to the bottom, if we get on the back end of this angiotensin system, angiotensin 2 causes the blood vessels to constrict. It also tells the adrenal glands to release aldosterone. So aldosterone, if you remember, plays a very important role in maintaining water and sodium in the body. So it increases your sodium resorption in your kidney tubules, and water follows sodium, right? So if it pulls the sodium out, then it pulls the water out. And so now the kidneys have increased the blood pressure and increased the blood volume by retaining sodium and water. And what happens then? You now have higher blood pressure, which is afterload, and you've got higher blood volume entering those ventricles as preload. So the kidneys increase preload and increase afterload to get themselves the amount of oxygenated blood that they need. So that angiotensin increases that afterload, and that aldosterone increases that preload. And short term, guys, most of the time in health, all these things balance out. In health, they balance out. But with long-standing and chronic disease, this becomes a never-ending, terrible feedback loop. All right, so here is the renin-angiotensin-aldosterone system. Starts up here at the kidney. So the kidney says, hey, not enough oxygen. It lets go of this hormone called renin. Renin comes in and takes this hormone called angiotensin that's sitting in our bodies and turns it into angiotensin 1. Then you have this angiotensin converting enzyme, or ACE, that's the acronym you need to know, comes in and transforms angiotensin 1 into angiotensin 2. Angiotensin 2 then causes blood vessels to constrict, increases afterload. Angiotensin 2 also tells those adrenal glands to release that aldosterone, which result in sodium and water retention. So increased preload this way, increased afterload this way in an already failing heart. So heart disease and kidney disease, these two organs do not play nicely together. It sucks. It really does. When you've got a patient that has both heart disease and kidney disease, the conversations that you have with the owner need to be very transparent and very clear. And you don't have to explain the renin-angiotensin-aldosterone system to them, guys. But as a general rule, if it's good for the heart, it's bad for the kidneys. If it's good for the kidneys, it's bad for the heart when you have disease in these two organs. In health, we can compensate. So we got volume and pressure overload in heart failure. Impaired renal blood flow, reduced renal blood flow turns on renin-angiotensin-aldosterone, which results in fluid retention. That fluid retention ends up sludging that blood even more, and we got more ischemic injury or hypoxic injury happens to the kidneys. So heart disease can affect the kidneys. Now, kidney disease, when your kidneys cannot conserve and preserve water, you've got volume and pressure overload on this side because they're not doing a good job of conserving and preserving water. They are constantly trying to have sympathetic activation. You've got an animal that's drinking to keep up and volume loading themselves. Often, if you remember, erythropoietin is produced. Poietin is responsible for telling the bone marrow to make those wonderful little red blood cells that carry oxygen to every other cell of our body. So if the kidneys start to fail, you have an anemia. You have less oxygen carrying capacity. You are less able to hold on to water. The sympathetic nervous system turns on. And so this becomes this vicious cycle. And one of the things that'll happen sometimes is when we start treating a patient for heart disease, we're trying to do some things that are bad for the kidneys to make it easier on the heart, right? We're trying to decrease blood volume, decrease the preload. So that is bad for the kidneys. The kidneys like fluids. They like water. They rely on water for their health. Without water, that chronic dehydration, they become azotemic, and azotemia leads to uremia. And so everything that we do therapeutically for a patient with heart disease can negatively impact the kidneys. And sometimes when we start treating heart disease, remember that those kidneys, remember from ClinPath, it takes 75% nephron loss to have elevations in BUN and creatinine. It takes 66% loss to have decreases in urine-specific gravity. So you can a lot of times have very normal blood work as far as BUN creatinine goes, and you start heart medications. Most of the time when we do this, we're asking those clients to come back in like 5 to 7 days after starting medications so that we can look at the patient, but also recheck those kidney values, because a lot of times starting to treat heart disease can unmask previously undiagnosed kidney disease that was at the low level, because now we're doing things that potentially harm the kidneys. And even though on paper this animal did not seem to have active kidney disease, once we start cardiac meds, then 5 days later we can go, oh crap, and you've got an animal with heart disease and kidney disease. It's like, which one's going to kill him first? And it's a no-win. It is a no-win. All right. Do you have any vague recollection of this slide? And I put this slide back in here. This is a slide from your anatomy and physiology books to give you that anatomic representation of your blood vessels. The arteries over here have more smooth muscle in them than the veins do. So this makes them more of the culprit in hypertension or exaggerated blood flow, because the muscle, they've got more muscle, which means they are more responsive to contraction and relaxation. That often is a component of sympathetic and parasympathetic nervous system stimulation. So again, just a visual for you. All right, more blood pressure meds. Hydralazine. I have never prescribed hydralazine, but it dilates just the arterial side of things. So it relaxes the smooth muscle by interfering with those calcium levels and allows the arterioles to relax. When we are relaxing those arterioles, we are reducing the amount of force the ventricle has to pump against. Therefore, we are reducing afterload. Again, can cause hypotension, vomiting, diarrhea, sodium and water retention. I don't see a lot of hydralazine out there like coming in with patients. Amlodipine, again, amlodipine is one we may use. It is, again, an arterial vasodilator. You see this more commonly. Every once in a while, there may be a place for nitroglycerin ointment. People that have angina, a lot of times will take a nitroglycerin tablet. Is a very powerful venous vasodilator in the face of angina, which we don't really think our animals get angina, but they can't talk to us, so that's really sudden onset chest pain. What nitroglycerin does is because it dilates the venous side of things, it decreases that preload, so it makes it less hard, less stretch on those cardiac muscle sites. Now, nitroglycerin, we don't have a tablet form that we use routinely in veterinary medicine. There is a topical form. It comes in a toothpaste tube. We really only use this in congestive heart failure. So if I've got an active little Chi-Chi who's got a 5 out of 6 murmur, who's got pulmonary edema and crackles and frothy coming out of her nose, I'm popping her with some Lasix, we may take some nitroglycerin. I'm going to pause. I'll be back. All right. Thanks for the sidebar. We may use nitroglycerin topically on like a hairless area, really the inside of the ear. You always want to put gloves on when you apply it because, again, it's topically absorbed. And it might help with acute heart failure. It doesn't have any long-term benefit for these guys. Now, prazosin. Prazosin is a little hot button topic in veterinary medicine because it is a mixed vasodilator. It blocks alpha-1 adrenergic, so the sympathetic innervation of smooth muscle. It is used adjunctively for congestive heart failure, dilated cardiomyopathy, hypertension, and pulmonary hypertension. I've almost never used it for urethral obstruction and urethral spasm in cats. So the smooth muscle of the urethra, we think it plays a role in helping to relax that and prevent urethral spasm. This is a hotly debated topic right now. So there's a lot of people that aren't using it anymore. I don't know what to use for block cats. I think I told you guys that. They're a real frustrating condition, but you're more likely to see prazosin prescribed to a cat with lower urinary tract disease than you are for a hypertensive animal. Nitroprusside, and you're not going to use it. ACE inhibitors, you need to know these right there. This goes back. ACE inhibitors, that acronym from the renin-angiotensin-aldosterone system. Benazepril, captopril, and nalopril. Those are going to be the most common ones that you see, and you are going to see them. These are going to be on your shelves. We use them all the time. We prescribe them, so they are reducing afterload in cases of heart failure. They're very commonly used. They act on that renin-angiotensin-aldosterone system that the kidneys initiate when they decide they haven't gotten enough blood flow. And then there is Viagra, sildenafil. I know I shared that story with you guys, that it was originally being studied as a vasodilator in use for humans with pulmonary hypertension, so high blood pressure in the lungs. Found out through the course of clinical trials that it causes the blood vessels of the corpus cavernosum of the penis to also dilate and fill up with blood and have the side effect of erection in men, and became a multi-billion-dollar drug that wasn't originally intended for that purpose. All right, there is a new one. There are a couple new drugs, guys. Chemotherapy and cardiology are two areas, and dermatology are two areas where we're seeing some new medications come out. Vetmedin was pretty new when I was first in practice, 2007. So I'd been in practice 7 years before Vetmedin came out. Vetmedin changed, game changer. Almesartan. So this is a new one that has just recently gained full FDA approval. It is trade name Symlintra. It is labeled for use in cats. So this medication has the advantage of being in a liquid formula that reportedly tastes pretty well. And its label indication is for systemic hypertension in cats. And it's also labeled for proteinuria in dogs. Because remember, that glomerulus in disease, the glomerulus is the tuft of capillaries in the kidney. When that starts breaking down, you can get protein loss. So proteinuria is often accompanied by late onset or early onset kidney failure, and the kidneys will also kick hypertension into gear as well. So this drug is labeled for hypertension. It works on that renin-angiotensin-aldosterone system by being an angiotensin II receptor antagonist. So it works at a slightly different place in that renin-angiotensin-aldosterone system than benazepril or enalapril or our more historic ACE inhibitors do. Okay, diuretics. We're getting there, guys. I swear we're close to done. Diuretics result in reduction of preload by decreasing blood volume. You need to know diuretics. You need to know diuretics. They're going to be on your shelf. You're going to use them every day. What diuretics do is they work at the level of the kidney. This is a heart drug, but it works at the level of the kidney. It inhibits the resorption of sodium and water in the loop of Henle in the kidneys. So that is what it does. So it does not let the kidneys do their job of conserving and preserving water and sodium. Remember, aldosterone kicks in and says, give me my sodium back, and then the water comes after it. So diuretics act differently, that they tell that renal tubule that they cannot do their job of resorbing sodium and water. That is why, and again, it is called a loop diuretic. It acts in the loop of Henle on that diagram of the nephron, guys. That is where these drugs act, and therefore we call them loop diuretics. They come in injectable forms. They come in oral forms. Chronic administration, and most of the time if you're starting furosemide, you're not ever stopping furosemide. These animals always have to have water present, because if you can think about, you've got an animal that can't conserve water because we're telling its kidneys to let go of the water, you've got to make sure that they have free access to water. They're going to be much more sensitive to dehydration. And long term, these medications can cause hypokalemia, so low potassium if given chronically. Now, you may also see torsemide prescribed. Torsemide is being used more and more in refractory congestive heart failure. It is 10 times more potent. So it's the fentanyl of diuretics, guys, is what it is. And so if you have a dog that comes in and it's already on pimobendan, benazepril or enalapril, and furosemide, and it's in heart failure again, you may be able to start torsemide instead of furosemide because it is more potent. The new labeled indication, Upcard CA1, is a actual veterinary prescription labeled drug that is torsemide for congestive heart failure. But you see it has that designation of CA1, which means they took the shortcut to approval right now. Now, a couple other diuretics. Thiazides are not used. Ignore them. Spironolactone. You do need to know spironolactone. And we call spironolactone a potassium-sparing diuretic. Furosemide and torsemide are loop diuretics. Spironolactone is a potassium-sparing diuretic. It antagonizes the action of aldosterone. So it decreases that sodium resorption from renal tubules. Now, spironolactone by itself does not have as much diuretic action as furosemide does. So just starting a congestive heart failure patient on spironolactone oftentimes is not enough to get them quality of life. So we will see spironolactone used in conjunction with. So you can prescribe furosemide and spironolactone and vetmedin and enalapril or benazepril with these congestive heart failure patients. Now, there is a new drug out there. Ding, ding, ding. It is, the trade name of it is Cardalis. It is a combination drug of spironolactone and benazepril. So you've got an ACE inhibitor and an aldosterone antagonist here. So you're able to give one medication to replace what historically you have given two medications. So you may see this on the shelves as you guys go into your externships. This is just some other chaos that may or may not help heart disease. Sodium restriction, they're super strict on this with people because, again, water follows sodium. Water results in increased blood volume. Increased blood volume increases I don't know. I personally, and most veterinary cardiologists I've heard speak and veterinary internists that I've worked with, we generally feel like it's more important that the patient is just eating something rather than really focusing on these restricted sodium diets. Some of the prescription companies, Science Diet, Royal Canin, they do make prescription formulas for heart failure, but they do not replace actual cardiac medications whatsoever. They just don't. And if the pet won't eat it, a lot of them historically have not been very palatable. Maybe they're better at them. I mean, these companies are always trying to do more to make their products better, to sell more. So maybe they're better. I don't know. That's not a hill I'm willing to die on. Some thought that the addition of things like taurine and carnitine, which are amino acid building blocks, which are particularly important in muscle, may benefit. Dilators sometimes can help with these guys. So aminophylline or theophylline are bronchodilators. We're going to have a lecture about pharmacology of the respiratory system. We'll talk about those a little bit more. Oxygen is, of course, super important. Sedation might be of benefit. Sedation is not treating the heart disease, but what you're doing with some sedation is you're treating the patient anxiety. Because remember that when you cannot breathe, God, it's a truly terrible thing. Breathing is the only thing that you never think about until it is all you can think about. So giving them a little bit of something like a butorphanol, remember it's a crap pain drug, it's a good sedative drug, but it does potentially have the side effect of respiratory depression. So you don't want to go super heavy on it. A little bit of butorphanol or maybe a little bit of diazepam, which has very little cardiovascular effects, may benefit your patients when they're super stressed out because they can't breathe. And then with our cat patients, clopidogrel. are hypertrophic cardiomyopathy cats. Remember, one of the biggest ways that these cats die, in addition to sudden onset congestive heart failure, is they form thrombi in their left atrium. And that thrombus breaks off, goes up into the aorta, and lands right at the aortic bifurcation called a saddle thrombus, right where in those back legs there. Clopidogrel is an antiplatelet medication. Again, we're going to talk about clopidogrel more in a different lecture. All right, our summary slides, and I have talked for 10 minutes over what would be my class time at this point, but I'm going to talk you through them anyways. So these drugs, these are the really important drugs. These are the drugs that you really absolutely do need to know, that you will see on the shelves, that you are using regularly. Atropine, we've talked about epinephrine, pemobendin, furosemide, torsemide, spironolactone, benazepril or enalapril, lidocaine, and sotalol. Those are the most common ones. Now, the telmisartan, the cardalis, those may be on the shelves too, and I'm sure they are probably going to end up being really good drugs that help modify the way that we are able to treat these diseases. Some more take-homes, guys. Really, 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 I've missed y'all, so I'm going to sit here and kind of soapbox for a little while. So much of medicine and so much of physiology, guys, is represented by flow. That process of flow, it hits so many different systems with medicine, physiology, and pharmacology and disease. You have got your blood flow down. Oxygen flows, urine flows, hormones flow, positive, negative feedback loops, digestion flows, the flow of electrical activity through neurons and nerve impulses, fluids flow through the body, the flow of drug action, pharmacodynamics, pharmacokinetics, it is all flow type states. I encourage you, because we've spent so much time, you guys, learning your blood flow. That flow, if you can start thinking in terms of flow, I think a lot of this is really going to start clicking and making sense to you guys. So just this lecture by itself, different flows. Blood flow, you all know blood flow. Cardiac conduction flow. I am optimistic that you understand cardiac conduction because I know you guys had it with Shauna and you had it with me last semester. Nervous system flow. How does the nervous system affect the heart rate and the vascular tone? The influence of the sympathetic and parasympathetic nervous systems is super important. So they all tie together. Hormonal flow. What do the kidneys do in the renin, angiotensin, aldosterone system? So that hormonal flow is important. You need to understand it in this lecture. The flow of electrolytes and the electrical flow as far as cardiac and vascular muscle contraction. Calcium's important. Water follows sodium. That is preload, y'all. Too much potassium affects electrical conduction activity. It slows it down. And the pharmacodynamic flow, how each of the drugs affects any of the above flow states. Most of our drugs, with respect to flow, they either support flow, make that flow stronger, or they block flow in some way at some point along these flows. That is where our drugs start to work. And so if it makes sense to your brain, I really encourage you to start, take that blood flow that you've learned and realize that flow applies differently, but that whole concept of flow is super important in medicine. Once you understand the structure of things, then you can understand the function of things. So the structure's anatomy, the function's physiology. Once you understand the physiology, you're going to be able to understand the pathology, how the diseases affect function. And once you understand how that whole body in health works, what the normal anatomy and physiology is, and you understand what changes in that normal physiology and anatomy in disease, that's the pathology, then medicine, surgery, nursing, pharmacology, when you start learning about these, all the rest starts to potentially make sense. So last semester, we studied structure, we studied function, we studied disease. These last 3 semesters, guys, they're going to be how the medicine, how the day-to-day of what we're doing in a hospital setting actually impacts the body, how it actually works, why we're actually doing these. And that's like being able to understand the why of anything. You guys know I have so many questions. I always have questions. I have so many questions. But being able to understand the why of what you're doing, because anybody can go in and work and just do the things, guys. It's automatic. Like, we do these things. So few people understand why they're doing what they're doing in healthcare, and particularly in veterinary medicine, because there's far more uneducated. And when I say that, what I'm talking about is classroom educated, not smart, but classroom educated, that can do the job and do the job well, but not really understand why they're doing the job. And that lack of understanding means that they're not going to pick up on certain things that someone with that understanding is going to pick up on and save lives. I mean, truly. So the process of learning these things, you guys, is going to evolve through your whole careers. As you get into externships, as you start looking at these patients, these bodies, these diseases, these injuries, and you start assessing them, treating them, watching them, monitoring them, all of this that we're talking about is going to start clicking into place. And you're going to have light bulb moments. And I'm looking forward to a lot of your light bulb moments. Just before your last test, there were like 4 of you that piled into my office the morning before asking really good questions, and there were things clicking as far as the drugs, and I saw light bulbs go on, and that was so fun for me, guys, because I already really like you, and I want you to be really successful, but I also need to feel like I'm doing my job, and wow. But no, very rewarding for me. So please, 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 please do not be discouraged if you're feeling overwhelmed. If things feel like they're not making sense, that frustration, if you watch that video I posted last week, maybe earlier this week, it was just in the group me, like, that frustration is the learning period. If you're frustrated, that means you're in the learning. You're somewhere between the ignorance and the knowing. You're learning if you're frustrated. Right now, most of your knowledge, most of the things that we have learned, that we have discussed in class, is theoretical. And the world in which you start to understand why those details matter and how those details play into the job of healing is right around the corner. It's just right there. It's right there. It's so close. It's so close. So close. And I'm excited for you guys. That is the end of my TED Talk. I am sorry you didn't get to see my husband shake his ass. Let me show you Chloe. Let's see if you are still watching. You guys have met Chloe. This is my little Make-A-Wish dog. This is my little Make-A-Wish girl. Hey, this is the girl that's got that giant thymoma there. And she's close, guys. She's a little skeleton. You see how bony she is. She's getting really bony. And then we've got the doofus among us, Lincoln. If you haven't seen Lincoln, this dog sucks. This dog has the emotional balance of a toddler. Always, don't you? You suck real bad, don't you? Yeah, you suck. Yeah, he sucks. And last but not least, come here. He's like, oh no, it's a trap. It's a trap. Come here, come on. Say bye to your kids. Say bye to the bonus kids. Say bye. Bye. I'll see you guys Monday. Looking forward to it.